Hi, welcome to Infusion Health, the podcast. I'm comedian Chris Patrick, a.k.a. Self-Proclaimed Powerman. And I'm here with my co-host and significant other, Rach.
Hey, guys.
Now, today we got an interesting interview. We've been meaning to get him on the show for a long time, and we finally got everything together and got him on the show. He's actually family. He's actually Rach's brother and my brother-in-law, a.k.a. bro-in-law. His name is John Cass, and he's a orthopedic PA, and he's going to tell us about some of the stuff he does in the operating room and in the hospital and what's going on today. John, thank you so much and welcome to the show.
Thank you. Thank you for having me.
So what exactly, you said you're a PA, orthopedic PAs?
Yes. So my main job is assisting orthopedic surgeons in surgery. And then, I'll see new patients in clinic and formulate an initial diagnosis and treatment plan and carry out conservative treatments. And then once it's decided that they have to go to surgery, then refer them to the orthopedic surgeon and then help out with the surgery. And
okay, well, you said once it's decided they have to go to surgery, what are some things, what are some factors or some things where you say this guy or girl needs to go to surgery?
Well, sometimes you can tell right away that they have to go to surgery, like an acute fracture, for example. But
what's an acute fracture?
Like, say you fell and twisted your ankle and broke your ankle.
Okay.
And it wouldn't heal correctly just by doing a cast if it was displaced. Mm-hmm. And it required surgery. Then usually we would stabilize the fracture in a splint and allow the swelling to go down for a few days and then go to surgery with and correct the fracture surgically with a plate and screws.
Okay, well, this happens a lot. Like, say you're on a camping trip or you're canoeing or something like that, and your foot slips on a rock. What are some things you could do? Okay, I'm out in the middle of the woods. I have no cell phone, no cell phone contact or anything like that. What are some things I can do to stabilize it? I've heard of like 2 boards and like tape or rope or something like that, or your pants or something like that.
Yeah. There's lots of ways to stabilize improvise a splint to stabilize a fracture. One of the main things that you want to do, though, if you're going to splint a fracture, is you have to make sure that you can feel distal or further away from the fracture site. They can move. Say if it's your ankle, for example, they can move their toes and they can feel you touching their toes, and they have circulation in their toes and stuff before and after you put the splint. Okay,
so what are some things like? Okay, I'm in the middle of the woods camping. Somebody slips on a rock. I look at their ankle. They can move it and all that. Obviously, you don't want to put a lot of pressure on it. Probably help them around and stuff like that until you can get them to a doctor. But then,
yeah, what you're describing there is a principle in splinting called splint it as it lies.
Okay.
So if you can't see, you don't have an X-ray, you can't see whether a fracture is actually dislocated also. As long as they have good sensation distal or further away from the fracture site, it's okay to just splint it as it's sitting in a position of comfort until they can get an X-ray and just see the orientation of the fracture.
Okay, and that's interesting too, because like when people hurt like their arms or something like that, it happens a lot in sport. I see a lot. You get that one good tackle in sports, like especially football, and was it torn ACL or something like that?
Yeah, that's a very common one we see in football players, basketball players. A lot of times, though, with that injury specifically, it's not a contact injury, so. It can be. Say in football, if somebody was getting clipped from the side of their leg, it would put a force on their knee, and they can get, it's called the MCL, the medial collateral ligament can be sprained, and then also the ACL can be sprained or torn that way. But a lot of times it's like in basketball or football, someone's trying to juke somebody, and they end up twisting their knee awkwardly, and then they get that non-contact kind of injury. You see it in basketball a lot.
Okay.
Well, like in football, like when they hurt their ACL, it's like, is it automatic? Like he hurt his ACL. I'm like, oh, he's out for the season.
Yeah. In football, especially because Okay, so if you're an elite level football player or athlete, you kind of need your ACL to stabilize your knee so you can run fast and everything. Not everybody needs an ACL if they don't need to have a stabilized knee, but an elite level athlete does, and it takes quite a long time to heal from it and everything like that. You have to give the graft, whatever you're using, time to heal in, and then you have to work on a rehab protocol. And for surgery, for football, after a surgery like that, it's like you're out for the season.
So just for our listeners, you work on the lower part of the body, so like hip, legs, the lower part, right?
Well, I'll do shoulders, elbows, wrists, hands, hips, knees, ankles, feet. Yep. Just I don't treat necks or backs.
Okay.
I know how to initially stabilize them or some initial treatment. But if it requires surgery, well, like I said, I'll just refer them to a different surgeon that I don't work with because they don't do spine.
Okay.
Well, I know, like one of the things, and he's just to let the listeners know, he's not a sports doctor. These are just references. Like one of the things, like you said, you work on shoulders, and being a bodybuilder, or not a bodybuilder, but lifting weights and stuff like that. One of the things we have is there's this thing called the rotator cuff, and I know a lot of pitchers throw that out later on in life. Like you said, when they get to an elite level, throwing like that can hurt your rotator cuff.
I don't see people. Typically, the people that I normally see in my practice that have a rotator cuff tear are like 60-year-old laborers, people that do a lot of overhead lifting.
Mm-hmm. So like our farmers,
or another common population of people are people that have a desk job.
Okay.
If you have a forward-leaning posture, you have bad posture and you lean forward typing on a keyboard, all the time. The front part of your shoulder, called the acromion, can rub on one of the rotator cuff muscles, and it kind of wears down, and that can lead to it impinges anytime you reach up over your head, and that can wear down that muscle, and eventually end up with a rotator cuff tear.
You can get that just at sitting at a desk.
Yeah,
so what you're saying is being in this position 8 hours a day, 5 days a week, stuff like that can.
So you have to be really cognizant of just your posture. If you have
so your body dynamics are super important at the computer, even.
Oh yeah. It's ergonomics are important in really any job, but like desk jobs, you want to try to put your chest out and try not to lean in as much because you can end up with shoulder trouble later on.
What about like stretching? Like sometimes when I'm working on the computer doing the stuff I do, trying to start a business, like every hour I was like, I get up and stretch out, go walk around, stuff like that. Is that good? Or
yeah, that's really good. Yeah, like every 10 minutes every hour to just get up and walk around, and because it's not just a strain on your wrists and shoulders. It can be a strain on your back, and just sitting all day, it's not good.
Well, especially like grabbing the mouse, holding on to that mouse all day, and
Mm-hmm. Yeah, you just made me think that another common thing in people in those type of jobs is carpal tunnel syndrome.
Yeah, carpal tunnel. Yeah,
yeah. So
I got a question. How often do you work with like workman's comp and stuff like that?
At least every day at work. Yeah, there's some paperwork to fill out for work comp. Yeah.
Because I know a lot of people have problems with workman's comp trying to not push the surgery, right?
On my end, I don't really see that. I have heard that.
Right.
A lot of times I see it from the other perspective. A lot of companies that, especially if companies have like a strong union, they'll have a representative that works with work comp for them. It's called a QRC, which I can't remember what it stands for. They'll often the QRC will come with the patient to the visit to make sure that they're getting all the treatment that they need, and just keep track of where the patient is in the process, if they're waiting for physical therapy or an MRI or surgery, or what they're where they are in this process.
Okay. My only question with that was when you prolong the recovery, arthritis can build in those places, right?
Potentially, yes. If you don't correct an injury timely, it can lead to arthritis and whatever. I mean, it depends on what the injury is.
Sure.
Say you fell on your outstretched hand at work and you broke your wrist, and it involves the articular surface of your wrist.
Mm-hmm.
If you didn't treat it, then either way you're more prone to arthritis. But if it's not reduced correctly to where it belongs,
right,
then it'd be even worse, and you'd be more prone to it.
Sure. What can people do to, what is the best thing people can do when they're working through all those programs to try and eliminate arthritis?
When they're working through work comp?
Yeah.
I guess just being diligent and not delaying treatment just because you're worried about your employment with the, it's, if you get hurt on the job, it's your right to be treated.
Right.
And there's no shame in that.
Right.
No,
granted, some people say, well, I can't go on work comp for a while because I don't get paid my regular paycheck, and I have to keep working.
Right.
So that's another reason why a lot of people will delay treatment.
Yeah, I also know some people, I didn't get hurt that bad, I'm not going to go fill out the paperwork. Please fill out the paperwork because you don't know how you're going to feel tomorrow.
Right.
Yeah, well, I think that's too. I think your employer wants you to document it too, so they know. I remember I hurt my back. It wasn't at work, but I think I was mopping or something. I just tore I pinched a nerve or something like that. My back hurt, and my boss called me up and goes, "You didn't do it here, did you?" I was like, "No, I didn't do it there. I think it just happened, And I was out for like a week around my birthday too.
I've a lot of companies, if you injure yourself and it didn't happen at work, they want you out of there. They don't want you coming back until you're totally healed up.
Yeah.
Because otherwise, if you aggravate it at work, then they bought the injury, right?
Mm-hmm.
But if it happened at work, they want you back as soon as you can, at least on light duty or something.
Yeah.
Just because they need your help, so you obviously have a job for a reason.
Keep the work flow going.
Right.
Well, one of the things I want to talk about is like when people do get hurt, especially when they hurt something. I know a lot of people that they get hurt, and the first thing they want when they go into the doctor is they want the drugs, they want the Vicodin, because there's the old joke, it used to be, you go into the doctor like, yeah, I had to go to the doctor. Oh, really? Is everything okay? Now it's like, yeah, I went into the doctor. What'd they give you?
Mm-hmm. Yeah.
Because I'm always a believer that there's the pain medication that does help, but you also got to get up and you also got to use it. And you also got to, you got to live with the pain a little to get past the pain.
That's true. And I think especially in our culture, a lot of people have expectations for instant gratification.
Yeah.
If you injure yourself, there will be pain.
Mm-hmm.
Mm-hmm.
But the opiates are there to, as an adjunct, but you're right. You need to get moving. There's one surgeon that I knew that after a patient had a surgery, they didn't want them dressed in their hospital gown. They wanted them to bring some clothes into the hospital with them and put on some clothes and not act like they're a patient. Act like they're getting out of there. You know what I mean?
Yeah.
You're just laying around in your hospital gown and people are waiting on you hand and foot. You kind of feel
Invalid.
like a patient.
Yeah.
Yeah. And you end up, it just takes longer to recover.
Yeah, because I've told friends like, I got to take these whatever it was, Vicodin or whatever. I got to take it to the pharmacies to get rid of them. They're like, give them to me. It's like, no, I'm not going to give them to you. You could sell those.
Yeah,
you hear about that kind of stuff all the time. It's that's a whole nother long discussion. The opiate crisis in our country, right?
Yeah, especially with one of the big things now is oxycodone. Everybody wants oxycodone.
Mm-hmm.
Yeah, and then eventually, the doctor, you get hurt, the doctor gives you opiates, and then you get addicted, and then the doctor cuts you off, and then what? Then you go get addicted to heroin, and
then you're in the ER for more pain meds.
Right.
Yep.
Yeah, because it's always been my thing. Like I said before, they help, because I remember when I hurt my back. You remember that, Rach, when I hurt my back, and they gave me the Vicodin, but they told me to take it every like 4 hours and stuff like that. But then I was also up and trying to move and stretch and stuff like that, to get myself through it. I don't think I even took all of them.
Yeah.
Yeah. Another premise that we have after surgery is to have medications of different classes other than opiates,
Sure.
in order to help treat their pain and reduce the amount of opiates that they'll have, whether it be an anti-inflammatory or there's several classes of medications that we use in order, just for that reason, to reduce their need for an opiate for their pain control.
Okay, well, what about like some of the what are some of the new advancements they're making towards healing? Because I know they had this one thing I saw it years ago where it's not even a cast anymore. It's some kind of thing that has like these round things. I saw this one guy, he had this thing on his leg, these round things, and these pins stuck into his leg, and as he walked, it helped the bone heal or something like that.
What it sounds like you're describing is called an external fixator.
Yeah.
So yeah, what that is a lot of times we'll do an X-fix if a patient, we are planning an open reduction internal fixation for a fracture. We do the external fixation to allow us time to get the bone out to length, so it doesn't heal. It start healing in an incorrect fashion, and then we are allowing the swelling to go down so we can close the skin. Then a lot of times we'll just take out the external fixator and then do the internal fixation with the plate and screws.
So what are some other new advancements they're doing? Because a lot of times now I'm seeing less and less cast. Because I remember you had that big plaster cast on your leg or something like that, and I'm seeing a lot. It's like, where's your cast?
Yeah, that is part of a paradigm shift, I guess. It depends on the fracture, but a lot of people are recommending more early mobilization so you don't get stiff and you don't need as much physical therapy after the fracture is healed. It depends on the fracture. There's also, we still use plaster.
Right.
Plaster's good because it's more compliant. It can
when you need to solidify the plates for a solid amount of time, then you'll use it. But then there's other mobilities that you can use instead of the plaster, right?
Yeah. So initially, if you use a plaster cast, for example, it'll flex more than a fiberglass one. So if there's swelling in the joint, you don't have to worry as much about the extremity getting strangulated because it's getting, because of all the swelling, it's pinching off the distal blood flow.
Right.
So that's why plaster is good for an initial fracture, initial cast care. But then a lot of times we'll switch to a fiberglass cast because it's stronger and it's more rigid.
And it can hold the bone it can hold the thing in place longer, whatever.
Right. Yeah.
Because I've also heard too where guys like me, they're like big guys, they get a cast, and then they got to keep going back getting a new cast because they're not working out, so their swelling's getting lower and lower, so they got to get a new cast.
Yeah. A lot of times you'll have that just because of the nature of the injury, there's going to be swelling, and if you have a cast overlying it, it's just not allowing it to swell, and anyway, it's actually squeezing some of the swelling out of where the injury is and pushing it more proximally into the heart and everything and the rest of the body. And so the cast can get loose, and then you got to put on a new cast. That's the other thing about casts.
What about like screws and pins and stuff that they're doing a lot now?
Yeah, it depends on the fracture. We don't want to do surgery if we don't have to, because there's it's fraught with risks of reaction to the anesthesia, including heart attacks and infection related to the incision site are the main ones. But if you have to do surgery, depending on the orientation of the fracture, there's all kinds of different treatment modalities depending on the fracture.
Right. And I'm another thing that has came in the last 10 years, 5 years, is the up of physical therapy, right?
Yeah, that's kind of what I was talking about, this paradigm shift to early mobilization for fractures. One that I think of that a lot of people will do early mobilization is if you have an elbow fracture. They'll kind of treat it with a mobilization for a couple of weeks and then get you mobilized with physical therapy.
So physical therapy. So they have you out moving and about and stuff like that.
A whole lot faster.
Yeah.
They'll put the cast on, have you on for about 5 weeks, and then get you right into physical therapy. Usually, right?
That's a typical for any fracture. For an adult, normal fracture healing time is about 6 weeks if you're not doing surgery. So then sometimes people don't need physical therapy. Like kids will heal faster too.
Oh, yeah.
For a kid, it's like a month.
Okay.
And then they usually don't need physical therapy at all. They just bounce right back.
Right.
So that's the thing too, because like I said, with advancements and stuff like that, are we making it, or is it going to be a way to where they don't even have to cut you anymore? They could go in with lasers or anything like that. I know I'm getting kind of Star Warsy.
Well, no.
They do have some more minimally invasive, smaller incisions. What I'm thinking of is called an intermedullary nail. So they'll use, say, on a hip fracture, certain types of hip fractures called intertrochanteric hip fractures. They'll do a nail down the center of your femur. Instead of fixing it with a plate on the side of the femur, there's a nail right down the middle, and they hold it in place with screws.
Okay, your femur. Where's your femur at?
Oh, sorry. Your hip bone.
Your hip bone. Okay, on the side.
Yep.
So it's back. The hip bone's connected to.
Yeah, the hip bone, the hip bone, thigh bone, whatever. The biggest long bone in your body.
Going down by your what's this? By your quad, by your calf. Or?
Yeah, it's underneath your quad. Yep, your feet. Yep, your femur, your thigh bone.
So what are some ways to because I know a lot of people like I'll give an example, like Steve Perry of Journey. He said he was just out, before a tour, out riding a horse or something like that. All of a sudden he had this like huge pain in his side. Then it's like you got to get a hip replacement.
Oh, really?
Yeah, he said it kind of just sprang on him. Like there was no like warning or anything like that.
Well, I don't know the details of his case, but I do see that a lot where arthritis is a degenerative condition. It's not like it's not like a fracture. It doesn't just happen instantly. It takes time. It's over time. Yeah. But I do notice a lot of times that when it's like a straw that broke the camel's back kind of thing, that some minor injury finally sets them over the edge, and then they really start to notice the arthritis that they had brewing for years.
Yeah. And with the older generation, and they usually say that the break happened before the fall, right?
Yeah. What you're talking about is osteoporosis. A lot of our older population. What I wanted to talk about too, you were mentioning like sports and lifting weights. I really recommend that as people age.
Thank you.
It increases your basal metabolic rate, so it makes it so the calories that you do take in are more efficiently utilized. But in our older population too, it strengthens the bones off of whatever muscles are being pulled against, So if you're doing, say you're doing squats or something, that would strengthen your thigh bone. And those,
yeah, there's your stabilizer muscles,
right?
Yeah,
and it used to be a death sentence to have a hip fracture, and it still actually is. All causes of death within a year of a hip fracture increased by 33%. So if you break your hip, you have a 33% chance of dying within the next year. So, and the reason a lot of people break their hip, as they age, is their bones are too soft. So I certainly recommend weightlifting to a point, just
light.
Right.
Start out light,
right? And then seeing your primary care provider and getting, depending on your age, getting screened for osteoporosis with DEXA scan or whatever.
I also see the older generation doing more cardio.
That's good. But from an orthopedic perspective,
Sure.
you do need cardio as an exercise.
Right.
But I would not recommend running, except to save your life.
Right.
So, walking, biking, elliptical, swimming, boxing are good cardiovascular exercises that don't do as much damage to your joints like running does.
Right.
Well, that's interesting you said it because I was running. I was working out with the kids, and I was on the track, and I was running. And my leg hurt. My lower, the back of my calf, not calf, my ankle hurt. And I said, okay, well, I'll take a couple weeks off. So I took a couple weeks off, and I started running again. And now I can't jog anymore. So I've been doing a lot more elliptical and biking and stuff like that, stationary bike and stuff like that, because I just can't run more. And I was running like about 1.5, maybe 2.5 miles, and I love doing it, but it sucks I can't do it anymore,
Yeah,
Get older, can't run. Yeah.
Except to save my life.
Yeah.
I run from your sister.
Thank you. But yeah,
So what are other like one of the things you said is definitely exercise, but what are some other ways in prevention of
and lifting those weights
and lifting weights? Yeah, you got to lift the weights.
Yeah. Well, just we alluded to it a little bit. Just especially if you're old, not trying to overdo it and show everybody how much weight you can lift.
Yeah.
I'm 100 years old. I can lift 100 pounds.
Those are the type of people that end up with
Problems.
a traumatic rotator cuff tear or like a biceps tendon rupture or something like that. So just, I guess, doing lower weight and higher reps. But like I said, I certainly recommend weightlifting in whatever form you can.
Yeah.
Just for overall health and for bone health to avoid hip fractures or other types of fractures as you age.
Well, you said, and not to confuse the listeners, but you said weightlifting. Now, we all know weightlifting is what we call resistance training. So also other resistance training is like push-ups, sit-ups, pull-ups, stuff like that. What do you think of stuff like that?
Yep, that's all good. That's all.
Yeah.
Yep.
So yeah, you can also do push-ups at home.
Yeah, you don't necessarily have to have a gym membership, and you don't necessarily have to have an expensive home gym or anything like that. You can just do some resistance exercises with your own body weight, like push-ups and chin-ups
push-ups, sit-ups, pull-ups.
Yep.
I do them all the time. Well, I try to.
It shows.
Well, John, this was definitely an interesting podcast. Thanks a lot for being on the show. And John's also a Viking fan. Go Vikes! And I'm gonna let Rach close us out.
All right. So we're coming to an end. History is lying. Build on lines of hate. On here, we're trying to build lines of love, and trying to make you guys your best advocate. John, I want to thank you for joining us.
Thank you so much for having me. It's been fun.
If you guys enjoyed what you heard, please subscribe and tell others. And Chris, lead us out.
Also, too, I want to know if they got any questions about you got a website, or is there any way they can contact you, email or anything like that?
Kind of putting you on the spot.
My email is john.cass@avera.org.
John.cass@avera.
Yep, AVERA.
AVERA. And if you got any questions as far as you got an injury and you want to know if you should get surgery, definitely seek the help of your care provider. Is that right, John?
Absolutely.
Yeah. I'm not gonna.
He's not gonna direct you in that.
I would likely depending on what it is, but yeah, recommend that if somebody injures themselves, they see their local physician.
Yep.
All right. Thanks a lot for joining us for this episode of Infusion Health, the podcast. It's been fun, and take it easy.